Okay, so let's talk about what happens when we have too much or too little fluid in our system. So first, we'll start out with fluid volume deficit, meaning we don't have as much fluid as we need. There's a deficit, right? We call that hypo, meaning less than or low, volemia, which is volume. So hypovolemia. So they've split the causes here into two kind of separate ways that this can happen. We either have water deprivation, meaning we're not getting enough fluid into our body, and this can happen for a number of different reasons, or we have a fluid loss, meaning we're getting enough fluid into our body, but for some reason we're losing that fluid. Either it's coming out through vomiting and diarrhea, or excessive diuresis, excessive diaphoresis, which is this is sweating. So we're losing the water that we have in our body. So let's just go back to water deprivation. How does that happen? There are conditions, hormonal conditions and what have you, that can cause a loss of thirst. And oftentimes this coincides with someone who is confused. So they're unable to really make the connection between the fact that they're not drinking and they're not feeling well, right? Confusion, though, oftentimes just plays a role in people just not drinking. And of course, if someone's in a coma, they need to be getting fluids, right, some other way. And then inability to communicate. This is, it's kind of self-explanatory, right? You have people who are unable to tell you when they're thirsty, and so they don't get enough water. So that's one way. We don't get enough water into our system. The other way is the water loss, and this happens especially in the older populations and in infants. It can happen in any age group for sure, but it's much more common in these populations where you have a lot of diarrhea and vomiting. You've seen this in patients where they've had the flu. I mean, this is very much how older people die from the flu. They dehydrate. And then I'm going to talk about diabetes in a second, but excessive diuresis, meaning our fluids are just being flushed out of our system. This can be a hormonal problem with the antidiuretic hormone, or it can be caused by medications. So medications like Lasix, which causes diuresis. And so oftentimes we have to really, really watch when we're giving patients something to purposefully diurese and flush out their fluids, that we don't overdo it. And so you'll see this question come up sometimes on exams. We'll talk about we're giving Lasix or furosemide. Furosemide. It's hard to write with this pen. That's the generic name for Lasix. So we're giving this medication, we're giving a diuretic. What should we be watching for in the patient? Well, you're watching for signs of this, which we'll talk about over here. So it can be a little bit confusing because you're talking about a patient who has fluid volume overload, and suddenly you're looking for signs of fluid volume deficit. And that's because we're giving Lasix, we're giving furosemide. We have to watch that we don't overdo it. And then excessive diaphoresis is just sweating, so that makes sense too as well. And don't forget that water follows salt, so anytime we have sodium chloride that's leaving the body, that water is going to follow it as well, right? So let's talk about diabetes a little bit. You can do one of two things here. You can memorize that diabetes causes hypovolemia. That's fine if that's easy for you. Skip the rest of this part. I think it's easier to know why, and then you don't have to necessarily think too hard about it. Remember we talked about osmotic pressures and oncotic pressure, and how that gradient can cause fluid to shift. So let's talk about, we talked a lot about albumin and how albumin can create, when we have a buildup of albumin in one compartment, it causes that oncotic pressure to pull the fluid towards that compartment. So very, very similar thing is happening here. It's along the same concept. And we're going to go back again to our kidneys. One of the things that the kidney does is as the fluids are coming in, there's this part here, the glomerulus, and don't worry about this for now, but what it does is it filters all of that glucose, the glucose that is in the blood. We want to keep that glucose, right? We don't want to get rid of glucose. Glucose is super important to us. So it filters through the neuron, blah, 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 or nephron, sorry. It doesn't matter for now. We'll talk about it in another unit. But the important thing to know is that it reabsorbs glucose back into the body, because we don't want to pee out our glucose. We want to keep it. At a certain point, however, it overloads this nephron, overloads the glomerulus, or the beginning part of that nephron. And what happens is it can only reabsorb so much glucose. If eventually, and remember that diabetes is, we've got a ton of glucose building up in our blood system, right? In our circulatory system, tons of glucose. The body's not breaking it down because we don't have insulin. Insulin's not working, whatever. We have a whole unit on that we'll talk about. So we have all this glucose that's in the blood, and we've only reabsorbed as much as we can. So what's happening now is we're going to pee out glucose. So we'll actually see glucose in the urine. If we ever see glucose in the urine, that's a sign that this is happening. We've got way too much glucose in our system. It's too much for the kidney to filter and reabsorb. So now the glucose is coming out. So the important thing here to remember is that glucose is actually a very, very large protein on its own. And so what happens when we have a buildup of proteins or osmoles or particles inside of a compartment? Oncotic pressure occurs. So what's going to happen is we're pulling, not only is that glucose coming out in the urine, but as it's filtering through the kidney, it's pulling the fluid along with it. It's pulling that fluid towards the glucose that's coming out of the body. So in that way, it can cause hypovolemia. And you will see this when we talk about diabetic ketoacidosis. We'll talk about this whole thing again, and how we treat that, and how dehydration is a huge part of diagnosing and treating diabetic ketoacidosis. But the idea here is that we've got a buildup of glucose. Glucose is a large protein that is eventually going to overwhelm the kidney. We're not going to be able to reabsorb it, and so it's going to start coming out in the urine. And because it's a large protein, it's going to pull all the water along with it. And now we have hypovolemia, or dehydration. And how do we diagnose? So to be honest, most of the time when we're like quote unquote diagnosing hypovolemia, we're looking at these things. We're looking at these manifestations here. These are the things that show up first. A patient comes into the ER, you're going to see that low BP, weak pulses, tachycardia. You're going to see all of those things long before you're going to get your blood work back to show you that your patient has high sodium levels, right? Or high osmolality, or high urine-specific gravity. So however, we do need to know these for testing purposes, and because when we do get that result back, we need to make sense of that result. We're never going to look at a patient's blood work that comes back with, a serum sodium level of like 130 and not question why, right? We need, not 130, 150 I meant to say, and not question why. And so we have to put those things together. And this is actually... all of these things here, all of them are following kind of along the same concept. And here it is. So we're talking about hypovolemia, meaning inside of our blood vessels, we don't have enough fluid. So let's take this kind of blood vessel and imagine it as a cup again, like we did earlier. The reason we focus on sodium and not potassium or anything else, chloride, whatever, is because sodium is the most populous kind of cation in the blood. So, or outside the cell, actually, in the extracellular fluid. So we have a lot of sodium. It's actually what causes most of what's in here in terms of osmolarity or like particles or solute is sodium. And so sodium can tell us a lot about what's going on in the extracellular compartment. And so let's look at this. If we have normal fluid volume level in our blood, and we have, let's say we only have 5 millimoles of sodium per 1 liter of water. And which is exactly what it's telling you here, right? That's how we measure. So our norm here is going to be between 135 and 145 millimoles per liter. What happens when we have a fluid volume loss? We still have the same amount of sodium. We haven't lost any sodium, but we've lost water. So now the percentage of sodium to water is much higher. So now here where we had, 135 millimoles per liter, we now have, 100, much more millimoles per liter because we have less water. The percentage or the ratio of sodium to water is higher. And so not only will we have high sodium levels, because the sodium levels are measured in millimole per liter, they're measured based on the amount of water. So we have low water, we still have all that sodium in there, it's going to be high, right? So not only will we have high sodium, because sodium is what's causing most of the osmolarity or osmolality inside of the blood, and that's what we're taking, our osmolality is also going to go down. Same concept as this, right? We've lost fluid, so the ratio of moles or whatever to fluid is higher. It doesn't necessarily mean we have too much sodium or too many osmoles. More than likely what it means is that we've lost fluid. Urine-specific gravity, same concept. What's coming out in our urine is now more full of particles. There's more per liter of particle. And so I like this little, this helps here, the higher the drier. If you're a person who just likes to memorize stuff and you want to just memorize high sodium equals hypovolemia, go for it. So I like to understand why, and this is why. All of these things are the same concept. The elevated hematocrit, we talked about it in a different video, but it's the same idea that inside of hematocrit is telling us how many red blood cells we have inside of our blood plasma, like the rest of our blood. What percentage of our blood fluid is red blood cells? If we lose fluid, then that percentage is going to go up. So if we do this with an erythrocyte sedimentation rate, we can actually measure this, where we can see how much of our blood is made up of red blood cells. If we lose fluid, that percentage is going to go up. So again, if you have an elevated hematocrit, it means we've lost water. The chances of us, instead of losing water, having made extra red blood cells is pretty low. So we draw the conclusion that we have low fluid volume. Same here. The amount of proteins hasn't changed in your blood, but the ratio of protein to fluid has gone up because the fluid has gone down. I know I've said that 300 times, but if you can understand that, then you understand all of these things. So let's go to the next slide. And like I said, this is usually how we're going to diagnose dehydration. We're going to be treating this much more quickly than waiting an hour for your blood work to come back. So I'm going to show you the big ones here, what really matters. Low BP, number one. This is the first thing you're going to see, because if you have low fluid inside of those vessels, you have less pressure inside of those vessels. So you have a low blood pressure, which results in weaker pulses and postural hypotension, meaning if somebody stands up, they get very, very faint. And their levels drop. If you've ever seen somebody with severe dehydration or postural hypotension stand up and just, the first time that happens to you, you'll remember forever and ever and ever from then on to pause at the side of the bed and ask the patient or like after they stand up to hold them for a second and make sure they're okay, or they will drop. Sorry, that's a side note. So low BP, that's our big one, number one. What happens if we have low pressure moving through our blood veins, our circulatory system? When it gets to the heart, there isn't as much blood to pump. So everything's slowing down, but the need for blood to our feet and our hands and all of our cells is still the same. And so the heart will recognize that it does not getting enough blood to the cells or to the rest of the body, and it will start speeding up in order to compensate, and you end up with tachycardia, and that's why we have tachycardia right here. It's actually a compensatory measure for this low BP. Eventually, this tachycardia here, it's basically your sympathetic nervous system kicking in, causing your alpha receptors and beta receptors in your heart to pump harder and pump faster, so that we can keep our cardiac output as high as we possibly can, so that we can get the blood we need to our cells. Eventually, that sympathetic nervous system response will give out. And that's when somebody will go into hypovolemic shock. At that point, there's not enough blood moving through your veins. Your heart gives out. Your heart is not able to keep that blood feeding your cells. So those are your two. These are, well, really your BP. So your low BP and your high heart rate are huge indicators of dehydration, especially together. Just keep in mind that this high heart rate is a compensatory mechanism. So if you get towards the end of if somebody's got really, really bad hypovolemia, you might not see this high heart rate because that compensatory mechanism has already kicked out. It's already done its job and it's done. We're at that point, we're in big trouble. Okay, so those are kind of your big ones. Let's talk about then some of the other things you see here. This makes sense. Dry mucous membranes, decreased skin turgor, those are huge signs of hypovolemia. In infants, sunken fontanelles. You remember those plates in the infant's head haven't met yet, and so those will sink in quite a bit. Don't forget that fluid has mass, right? It weighs something, and so if we lose part of what we have in our body when we weigh ourselves is fluid. That's why you'll see people who have to drop a weight class run with, like, I used to have friends who were wrestlers, and they would put on like a snowsuit and garbage bags over their snowsuit, and they would go for runs to sweat out as much fluid. So they were doing this excessive diaphoresis, to sweat out as much fluid as they could, because you actually lose weight very, very quickly that way. And then they would go back to drinking as soon as they did their weigh-in. This is part of the reason we watch our patients who have, especially patients who have CHF, and we'll talk about that in another unit, but they have fluctuations, right, in their fluid volume. We'll talk about what all that is, but this is part of the reason we weigh our patients every day, because it can tell us if a patient is 71.2 kilograms last night and tonight they are 70.6. Or sorry, not tonight, but the next day. Usually we weigh at the exact same time every day, usually before breakfast, right? It can tell us something. Now, it's important to remember with all of these manifestations and in every unit and every system that we're looking at in nursing, it isn't just one or two things that we're looking at. We're looking at the whole picture, because yes, this weight loss could be due to anything. But if we have this weight loss plus tachycardia and low BP, plus a low cap refill time, it's putting the whole story together to tell us what's going on in the patient's body. Cap refill time is really, really important if we're checking circulation, right? Because we want to see if that blood is going down to how fast the blood is making it to the extremities. So we push down on the fingernails, see how fast it comes back. I also find that as I worked cardiology, I started out as a cardiology nurse. And pedal is funny. Pedal pulses, a lot of nurses don't do them, but cardiac nurses, it's just part of our basic assessment. I mean, I can find you a pedal pulse in 2 seconds. They're typically at the beginning, they're very difficult to find, but you get so fast at it, you'll find them very, very quickly. So if you're doing pedal pulses or cap refill time, your cap refill is slow, or your pedal pulses are they're slow as well, or weak, or what have you, it's telling you something about your circulation, your fluid volume. And don't forget that circulation is one of your ABCs, right? It's incredibly important for maintaining homeostasis, for staying alive, because what happens is we go into hypovolemic shock. Okay, so how do we treat? I'm going to ask you to check in with your prof about this slide, because normally in real life and for NCLEX, I know you guys know that I do a lot of NCLEX tutoring and NCLEX prepping, so I'm pretty familiar with how we need to answer questions on NCLEX. So normally our treatment for this kind of fluid volume deficit is an isotonic solution. So normal saline or D5W. And now you're confused, right? Because this says D5W and it's calling it hypotonic. But I'm going to explain that in a second. But let's just walk it through, okay? This is our blood vessel. We know we're low on fluid. We know we've got this normal amount of solute. So in terms of our electrolytes, they're pretty much the way they always have been. We have the right amount of sodium in there. We just don't have enough fluid. So yes, let's see what would happen if we gave a hypotonic solution. So we're just giving fluid in here. It's going to eventually it's going to eventually fill that up, and it kind of makes sense. And in some cases, I guess, like where you have an extreme dehydration, you might use that hypotonic solution. But most of the time, what we do is we just add fluid that is normal saline. So normal saline has inside of it, so normal saline, this is this on the bag, sodium chloride, whatever. It has the same ratio of sodium to water as what's in your blood, right? Which makes it an isotonic solution. Your isotonic when it basically has the same ratio as this. D5W has this same ratio, but instead of being sodium to H2O, its osmolality is the same, but that osmolality is created by dextrose, which is basically just a form of sugar. It turns into glucose, turns into energy, right? So the ratio of solute to water is the same as your body, but instead of it being salt, it's sugar water. And so what happens is if you walk that through, if we give fluid and we give with dextrose, the body very, very quickly takes that dextrose and uses it for energy. And so it's out of the blood very, very quickly. And so we end up with basically a solution that in that case is hypotonic. Do you understand that? So if this is a really confusing concept, if you look online, you're going to get some websites that are going to tell you that D5W is isotonic, and some that are going to tell you that it's hypotonic. And that's why. Because it's isotonic when we give it. It's got the same ratio of moles to fluid or water, whatever. But those particles of dextrose are metabolized very, very quickly, and then it becomes hypotonic. Now, all of that to say, on a test, if you have a test question that's asking you, or your patient has hypovolemia, and you know it's not going to say that, it's going to give you a bunch of these signs, and you're going to have to put it together that the patient is hypovolemic, and then it's going to ask you maybe what you anticipate the physician ordering. It's going to be on NCLEX, the answer is going to be an isotonic solution. It's going to be normal saline or D5W. If your answers on your test are normal saline, Ringer's lactate, or lactated Ringer's, or whatever, you're golden. Just pick normal saline or D5W and you're happy. If your options are hypotonic, isotonic, and hypertonic, that's where you're going to come into problems. So I would ask your teacher what would be the answer then, because typically and in real life and I know in the like Lewis, Heitkamper, and Porth, we're giving isotonic solutions for dehydration, not hypotonic. And D5W is still the right answer because it can be considered an isotonic solution. So I'm going to leave that in your hands. All your profs are great. I've talked to all of them. They have so much experience nursing, so I'm sure that they will be able to kind of clear that up. If it becomes an issue on a test question, you can let me know, and I can possibly just have a chat with the profs and just try to clarify for you. But if I were you, I would just go and ask, we have hypovolemia. Are we using isotonic or hypotonic solution? I get why they're saying hypotonic. And when I was in school, I always thought, well, why aren't we giving, but it's just in real life, we're just giving normal saline. Most of the time it's normal saline. So I'm going to leave that with you to deal with.